Greetings, everyone. Good morning, good evening. Welcome to the 102nd session of the online Optom learning series. And today we have with us Dr. Andrew Pucker. Dr. Pucker earned his OD, MS, and PhD degrees from the Ohio State University. And he's currently an assistant professor and chief of the myopia control clinic at the University of Alabama at Birmingham. He has been the principal investigator of a National Eye Institute funded project, which is related to myopia development. And he is currently managing other projects which are related to refractive error, dry eye, and contact lenses. He is also the contributing editor for the Contact Lens Spectrum, a fellow and a diplomate of the American Academy of Optometry, a fellow of the Scleral Lens Education Society. He has also received a number of other honors, which includes, I would just mention the two important ones, which includes the William C. Elsie Fellowship and the Irwin M. Borish Awards. So I'm sure everybody of us knows who is Dr. Borish. We have been, reading his books in our optometry life, and he has been awarded with that honor as well. And today, Dr. Pucker is going to talk to us about how can we help patients who have contact lens intolerance. So thank you, Dr. Pucker, for giving us your time. It's a very late evening there in that part of the world in the US. But thank you so much for taking out time for us. Let me just leave the screen time to you now.
Thank you for the very kind introduction and for having me. It's a great honor to be here with you all and part of your very impressive series. Over 100 people spoke, it sounds like, in the past year, or actually less. So I'm honored to be one of you today. So today I'm going to be talking about one of my passions, which is treating contact lens intolerance, or said another way, treating contact lens discomfort or dropout. A little background before I get into a few cases. This is going to be a case-based lecture, and actually I think this will really help our optometry students here too, because I'm going to start basic and then go to some more complex stuff and build upon some basic principles that I think we should all know to be good optometrists. So it's pretty well known that most contact lens wearers have some discomfort. A seminal study from Begley found that about 79% of contact lens wearers have at least some discomfort. That doesn't mean that they're uncomfortable all day, but they just notice some symptoms throughout the day that are bothersome. And some people, of course, have symptoms the whole day, and we'll go through some cases about that as we go forward today. Contact lens discomfort is actually the top reason why people discontinue contact lenses, and that's really the heart of a lot of my research. And it's probably the main reason why the contact lens market hasn't grown over the past 20 plus years. We've had many better materials made. There's now silicone hydrogels, there's daily disposables. There's always something new and better coming out, but that really hasn't changed the market. And really, I think it's because of discomfort, and there's a lot of stuff going on with discomfort. I'll talk about some of it, but you could do several lectures just on this topic. Just so everyone's on board, since I do know we have some young optometrists or aspiring optometrists in the group, I want to give you what the current definition of contact lens discomfort is. So about 7-8 years ago, the Tear Film and Ocular Surface Society came out with a position paper, and they defined contact lens discomfort as an episodic or persistent adverse ocular sensation related to contact lens wear. This may cause some visual blur or maybe not, but eventually these people start to stop wearing their contact lenses all day, and eventually they may just completely drop out of contact lenses. And there are many reasons why this may happen. Here is a list that the TFOS workshop came up with. So there could be, contact lens factors like it's ripped or torn, or maybe just you're aging, you have dry eye. There's a lot of different things that could be going on. But the typical person with contact lens discomfort, they start off happy. They're probably very motivated to wear contact lenses, but eventually they start to struggle. And as time goes on, maybe they only wear their contact lenses for special events, for pictures, for weddings, that sort of thing. And then eventually they just get fed up and they completely stop. And that highlights kind of the ultimate treatment for contact lens discomfort, which is removal of the contact lenses. So if the symptoms go away when the contact lenses are off, that's contact lens discomfort. If they persist, they probably have some dry eye, and sometimes the two of those go together. But with contact lens discomfort, it's the contact lens itself that's inducing this sensation. I just want to hit home that discomfort is really bad, and I kind of mentioned this already, but I wanted to show you this seminal figure from Pritchard from 1999, and we can see on the x-axis here all the different reasons why someone may stop wearing contact lenses. So it could be because of inconvenience, they lost their lenses, they found that they're too costly, but really it's discomfort. So we can see here that discomfort accounts for roughly 50% of all contact lens dropouts, and that's essentially equal to all the other things combined. And I've gotten really interested in this over the last several years, and I just published a review paper on this topic. And I know this is a busy figure or table, but I just want to highlight that there's several studies that have been done on contact lens dropout, and in every case where they're looking at established contact lens wearers, the reason for contact lens dropout is ocular discomfort. There are a couple studies on new wearers or neophyte wearers, and in that case, poor vision was the top reason. But in general, once you become a contact lens wearer, you've worn them for a little bit, discomfort is why you stop wearing lenses. And really the aggregate of dropout frequency related specifically to ocular discomfort is roughly 21 or 22%. I know the Pritchard study found around 50%, but there is some variability in the research out there. So how might a contact lens be inducing this discomfort? So here is a mocked up model of an eye. You can see here's a cornea and the tear film, and the tear film was made up of an aqueous mucin layer and an external lipid layer. This is not to scale, but when you put a contact lens on that eye, it splits the tears in two. So again, we have our cornea, we have a post-lens tear film, we have our contact lens, a pre-lens tear film, and then we have our external lipid layer. When this contact lens is on the eye, it splits the tears and makes them thinner and makes them less stable, and that could cause evaporative dry eye-like symptoms. And actually, the contact lens itself may start to absorb some biomolecules, so the lipids or proteins within the tear film can start to deposit on a contact lens, and that may further destabilize the tears, resulting in those unfortunate symptoms. So that's kind of the background. There's a whole lot out there, but I just wanted to cover the highlights before we got into our 4 different cases. So our first case today is a 34-year-old female. She presented for her annual eye exam while wearing her glasses, and that's a tip-off there. You have a contact lens wearer come in and wear glasses. They're probably pretty unhappy with their contact lenses because most contact lens wearers, you can't get them off them, right? The patient reported that while wearing her contact lenses, she was experiencing dryness and irritation, and she was only able to wear contact lenses for about 8 hours. And really, our goal, I think, is to have our patients to be able to wear their contact lenses for at least 12 hours per day comfortably. So this person's not meeting that bar by any means. And probably the discomfort was starting almost immediately, but she was just kind of fighting through it for her workday. The patient reported not using contact lens solution and not wearing them overnight. So overall, pretty good, though I do recommend a solution for my daily disposable contact lens wearers just in case they get something in their eye and they need to clean their contact lens midday. The patient did note that they changed her spec RX a little bit last year, but really didn't notice the difference. But overall, reports no other visual or ocular symptoms. We look in the chart and we see the patient's wearing AccuView Oasis 1-day contact lenses. She's a average myope right around -3. She's wearing fairly new contact lenses. This material, at least this 1-day form of Oasis, hasn't been around that long, and she's seeing pretty well with it. We'll come back to that in a moment, but we do our refraction. She's not wearing contact lenses. We find that she's roughly stable. I'm going to tell you. We get a little more history and find out that there's no systemic ocular family history of note. She has a normal anterior posterior ocular health, and she's seeing 20/20 with her glasses. But of course, she noticed that her contact lenses are uncomfortable, they feel scratchy, and she just doesn't like wearing them. So we got out some trials that day. We picked out the same ones she was wearing last year, put them on. We saw that she could see 20/20 with them, no over refraction, and that her contact lenses fit really well. They had good coverage, centration, and movement. But she hated them, so we weren't going to have her stay in them, right? We wanted to switch it up, give her a new contact lens. We specifically picked the Dailies Total 1, very similar prescription. We put it on. We found that she could see 20/20 with it, and that she had, again, a good fit with good coverage, centration, and movement. So what we did is we educated her on that day, and then we finalized her spec RX and told her that she should try these contact lenses out at home for about a week. So that's what we did. We just wanted her back in a week. We wanted to send her home with these contact lenses just to make sure that these symptoms didn't pop up again. Because in office, it could be very different than at home when they're reading on a computer all day. You know, most of us are on the computer several hours a day, and you're not blinking, and that may instigate some symptoms. So we wanted her to try these out in real life. The patient came back 2 weeks later, and we found out that she was actually very comfortable with her contact lenses. She could see well. We decided that we were going to finalize the contact lenses that day. We educated her how to take care of them well, because good hygiene with contact lenses actually promotes good comfort. And we just said, come back in here unless you have any trouble. So this is a very simple case, but it highlights some important points that I want everyone to keep in the back of their mind when they're prescribing contact lenses. And this paper here, this seminal paper, kind of highlights the points I want to talk about. So Graham Young published this paper back in 2002. It was a study that recruited patients who dropped out of contact lenses. They could have been wearing whatever contact lens, but they dropped out. And they had actually 236 people who had dropped out of contact lenses. Big study. And they followed them for 6 months after refitting them into a different contact lens. It wasn't any specific lens. They just picked one that they thought would be good for that patient. And they found that initially that 96% of the patients could accept the lens, and then 77% of them were still wearing them 1 month later. And going forward to 6 months, 74% of those patients were still wearing contact lenses, or 26% dropped out. So point one is that if you have an uncomfortable contact lens wearer, like in the case we just saw today, that you could just simply switch to a different lens and they may do way better. The other is that you may want to follow them fairly closely, because you noticed here most of the people who did drop out of contact lenses did so within the first month. So if you're a savvy person with practice management, you may give them a call like 2 weeks later, or at least have them come back for a follow-up like I did, a week and a half later, to make sure that they were still doing well. This brings us to case 2. So we're going to build and get more complex as we go. Case 2 is a 28-year-old female, came in for annual exam. The patient reported that she's been having problems with her habitual contact lenses. She's been wearing them for 10 to 12 hours per day, but they've only been comfortable for 4, 5, 6 hours a day. So much less comfort than we would hope for. And I think this highlights 2 questions that we should be asking our patients. One, how long can you comfortably wear your contact lenses? And then how long do you wear your contact lenses each day? And if there's a difference between those 2, that's when you may want to start talking about alternative treatment options. This patient is wearing a monthly lens, though she replaces them every 2 weeks, which she says helps with comfort, but that's bad for your pocketbook. You're, basically wasting money. You're going through 2 years worth of contact lenses in 1 year to try to make yourself feel comfortable. And maybe because of that, you should switch contact lenses. But overall, the patient was, fairly happy with, things, except that her vision got blurry, and then she sometimes had some discomfort. We asked some additional history questions. We find that there's no medication use, no systemic ocular family history. When she puts her glasses on, she can see 20/30 and 20/25 out of them. That's not unexpected for a contact lens wearer. They usually keep their glasses for several years. So they may have their glasses for 5, 6 years, not see great with them because they're mostly wearing contact lenses, and they're totally okay with that. Though, if you can give them a better pair of glasses, I would at least suggest it to the patient. And upon evaluating their eye health, there's no issues going on. The patient, per the chart, we noted that she was wearing the AccuView Vita we didn't really evaluate him because the patient wasn't happy with him. So don't waste your time. We got a good refraction because we always want to do that when picking out a new contact lens. And in this case, we went with the Clarity 1 day, and a student was helping me with this. And when a student's working with me, I just have them pick their favorite lens. I don't really have a preference because one lens might work well for one patient and not for another, and vice versa. This patient, started off with the Clarity 1 day. We put it on. The patient could see great, 20/20 in both eyes, no over refraction. It fit well. And we educated the patient specifically at that visit. They were switching contact lenses because of discomfort. And, we went through hygiene and all that just to make sure that they were taking care of their contact lenses. The patient came back 2 weeks later for their follow-up, and she reported that she was, kind of liking her daily disposable contact lenses, the Clarity. She said they felt a lot more comfortable, less dry, but she was still getting some blurriness with blinking, that sort of thing. So that kind of tipped off to me that the patient still wasn't fully happy. So what we decided to do was switch contact lenses again. This time we went with the Dailies Total 1, just like with the first patient. Put them on, had good vision, good evaluation. They fit well, good coverage, centration, and movement. And we educated the patient that, go home, try them out. And they actually came back 2 weeks later. She came back 2 weeks later, and she was happy. And we wanted her to then come back in a year. But what actually happened, we told her to go away in a year. She came back in July, so just a few months later. And their patient reported specifically that she was having discomfort with her Dailies Total 1. And we asked her, do you like your Dailies Total 1 better or the Clarity? And she still liked the Dailies Total 1 better than the Clarity, but she just wasn't happy overall. She could wear the lenses for about 5 hours, and then have them comfortable, not ideal, but she could stick it out like with other lenses until 12 to 14 hours to get through the day. But overall, not meeting her needs. So, the contact lenses could have been a bad batch or something, so we wanted to check them out. They're daily disposables. You could get a whole bad pack for some reason, unlikely, but you want to take a look anyway. We evaluated the contact lenses. They looked good. She saw well in them. And since we had, a patient in these two different premium lenses and they were unhappy, I think that at that point it was a tip off to start investigating dry eye symptoms. So we did a dry eye workup. We looked at tear stability with tear breakup time. The numbers, we did it 3 times, were under 10 every time. That suggests that the person's tear film was unstable. They were having probably some evaporative dry eye. We did a measure of tear volume with a phenol red thread test. It was more than 15, which is a good number for this test. So that means that the patient had adequate tear volume. We did a validated symptoms questionnaire, specifically the contact lens dry eye 8 questionnaire. And she had a score of 21. And anything more than 12 on this survey indicates that you may need to change a contact lens to improve it. So this person was highly symptomatic, like they were saying. We just wanted to quantify it so we could track this patient over time. And they also had some abnormal meibomian gland secretions and some capped glands. And this is a picture that my colleague, Anna Tishner, took of someone who had capped glands and poor oil. So here's the video. And you can see the oil kind of coming out. It's like toothpaste. And this is exactly what my patient looked like in office. So we're really thinking this person has some sort of evaporative dry eye, along probably with contact lens discomfort. So what I decided to do is start simple. We educated the patient that she had evaporative dry eye disease, and then we wanted to prescribe a first tier dry eye treatment, which was artificial tear. In this case, I picked Sustain Complete, and I asked her to use it 4 times per day, and that she could use it with her contact lenses. So before, after, and during contact lens use. The patient went away for a few months. That happens with happy people, but we got her back in, 3 months later, and she reported that she was happy with her Sustain Complete. She said that it relieved her symptoms and that she was overall comfortable with her contact lenses. So I've seen her since, and she's still doing well. Are you allowed to use artificial tears with contact lenses? Well, at least in the United States, the FDA says you shouldn't. The Food and Drug Administration says you should not use artificial tears with contact lenses. You should be using a drop that's specifically approved for use with contact lenses, and we generally call those comfort drops. But I've done 2 randomized trials with sustained complete, no safety issues in my contact lens wearers. And after that, I decided to do a literature review, and I published this not even a year ago. And what I found in this review was that you can use contact lens rewetting drops and artificial tears with contact lens wearers. They do really well, it's effective, and it's safe. So what I like to recommend is just go, pick a good drop, and that should really help out with their comfort. Yeah. But really, what one should you pick? There's a lot at the store, at least in the United States. When you go to the big box store, you see all of these different boxes. It's kind of overwhelming for the patient. And what I found in a meta-analysis, which is a studies of studies, is that if you compare each different artificial tear on the market, there's really no difference between them. So what I just like to recommend is just give the patient the sample you have and have them get something like that, just to make sure they're getting an artificial tear. Sometimes it's hard for patients to pick out the right drops, but really it doesn't matter which one. They all work about the same, and it really, I think, would make them better off in the end for using that. It makes their eye more lubricated and more comfortable, and it's pretty simple and cheap compared to other things that you could do. Moving on to patient 3, we have a 24-year-old white male, reports to clinic with significant self-reported contact lens discomfort. The patient from the chart we note that he's wearing Air Optics with Hydroglide, pretty standard monthly lens. The patient was using multi-purpose solution, up-to-date solution, pretty good. He's been wearing contact lenses for 8 years, and he actually has very heavy visual demands. He's a medical student. He was at that time, I think, a fourth-year medical student, and now I still see him. He's a resident here at UAB. But what we did is our basic workup and some extra stuff, because we were at the time promoting orthokeratology. But we did our full workup. The patient was having discomfort. We also did our dry eye exam right away in this case, because I was pretty worried about that. So overall, simple refraction. This should actually say -2 refraction. Sorry about that. Normal Ks and normal corneal diameter, horizontal visible iris diameter. If we look at the dry eye data, we see this patient has, at least in the right eye, a unstable tear film. The tear breakup time is under 10. The tear meniscus height is under 0.2, suggesting that also this patient may have some aqueous deficiency, and the contact lens dry eye questionnaire is at 12, which is the point where you might consider making a contact lens change. We did a topography just to make sure this person could wear orthokeratology, because he was somewhat interested in it. We talked about different contact lens or orthokeratology options for this patient. There are many in the market, but these are the 2 we primarily use at UAB. One is the Paragon CRT. It's made by Cooper Vision now. And then the Euclid Emerald lens. The main difference between these 2, just for simplicity, is that the Paragon CRT uses a fitting set, whereas the Euclid lens uses a empirical system, meaning you send the stuff to the company and then they send you a lens. So what we did is we educated our patient about orthokeratology and other lens options, and in the end, the patient ended up indicating that he wanted to go forward with orthokeratology because it would free him from glasses or contact lenses during the day, which would help him with patient care. And he was aspiring to be a surgeon, like I said, so he's going to have long days. What we did is we sent our parameters to the company, and we scheduled our patient back for a visit in 2 weeks, and we picked that time just because that's about how long it takes for us to get the lenses in stock. The patient came back when the lenses arrived. We put the contact lenses on, and we found that he had really good acuity and that the contact lens centered well and the fluorescein pattern was great. So here is an orthokeratology lens on an eye. This is a video I took. I'm going to play the video, hopefully. Sorry, it's not playing. But you have a fluorescein pattern where there's central applanation, so the center part of the lens is squishing probably the central part of the cornea. The fluid is pushed to the mid-peripheral part, and that's what corrects your refractive errors. You flatten the central part of the cornea to alleviate refractive error during the day. So when you take the contact lens off in the morning, you can go free without any contact lenses at all. The patient was able to very easily apply and remove the lenses in office. He was an established soft contact lens wearer, so he did really well in office, and he was able to take them home that day. I'm skipping a few visits for time. I know we're trying to keep this on schedule since it's awkward times for all of us, but the 1 week visit went really well. The one morning visit went really well. And at 1 month, the patient had really well-centered orthokeratology lenses. So when we look at topography, we want to see that central flattening, like I was talking about with the lens image I just showed you. So we have central flattening, nice and even, and that allows you to get good acuity. The patient was not wearing contact lenses during the day, which actually got rid of basically all of his dry eye signs and symptoms. And when we had him redo the contact lens dry eye questionnaire, his symptom score went down to 7, which is basically asymptomatic. So what we ended up doing was finalizing that prescription, and we scheduled back for a visit in 3 months just to make sure he was still doing well. And with my orthokeratology patients, I like to see them, at the dispense the next morning, 1 week, to make sure they're doing well. They're all on track. They have no trouble getting lenses on and off. Then at 1 month, if they're doing well, I finalize it, and then I see them back at 3 to 6 months just to keep close an eye on them because they're wearing this while they sleep. The reason I was starting to promote orthokeratology within the clinic is because I was conducting a study funded by Euclid Systems, and specifically what we were doing was recruiting patients who were struggling with their soft contact lenses. So they had high contact lens dry eye questionnaire scores, and what we did is we refit them into orthokeratology, and what we found was that 72.5% of those patients, roughly 30 out of 40 patients in the study, were able to successfully switch to orthokeratology. They had their symptoms dramatically reduced, and they became happy, healthy contact lens wearers again. And also they actually had some better ocular surface signs. Their conjunctiva had less staining, and that just makes sense. If you're not having a contact lens on the eye during the day, you're not having that irritation present, and maybe your eye's surface will be healthier because of it. So this brings us to our last patient for the day. We have a 30-year-old female. She presents for an annual eye exam. She has complaints of dryness, burning, watering for the past 3 months, and a contact lens intolerance. She came in wearing her glasses. And specifically, she noted that when she had her contact lenses on, her symptoms were much worse. So that's a clear sign this patient had contact lens discomfort. She's tried a variety of things, such as artificial tears. That didn't help. She's tried a whole bunch of different contact lens options in the past. She's tried soft contact lenses by toric, gas permeable lenses, piggyback lenses, and it just wasn't doing it for her. This patient is someone who has very high visual demands, college professor, avid reader, so we need to make her be able to see well. We knew this patient had a complex contact lens history. She was wearing bitoric lenses and piggyback lenses. Just for the students, for your knowledge, a piggyback lens is where you have a hard lens on top of a soft lens, and that sometimes helps with comfort. But we did topography. We saw this patient had a fair amount of with the rule astigmatism. That actually helps, I think, with some contact lens fits. But overall, she was about -4 for a sphere and about 4 diopters of astigmatism, though she could see really well with this when it was corrected with Fropter. Since the patient was noting symptoms, we also wanted to do a dry eye workup, and we did. We looked at tear breakup time like I did with our previous patients, and she had tear breakup times under 5 seconds, so really fast, so it's indicating evaporative dry eye. She had normal phenol red thread, suggesting there's probably good tear volume, so this is kind of your typical dry eye patient. Usually it's evaporative. This is the case here. And it's probably evaporative because she has some meibomian gland dysfunction. In this case, I did meibography or images of the meibomian glands. We could see this is an upper eyelid, and this is a meibomian gland here. I'm pointing at it with an arrow. These glands should actually go the entire eyelid distance here. So they should go down here. And this is actually an area of atrophy. So the glands are gone here where they should actually be. So that's suggesting there's some meibomian gland damage. And it's the same case here with the lower eyelid, maybe even more so. So we knew she had some pretty bad dry eye, so we wanted to try to get that under control first before we did a contact lens fit. We prescribed Lotemax, which is a soft steroid, pretty common to do that here in the United States. And we often do that to see if something like Restasis will work. So if there's an inflammatory part to the dry eye that's treated with Lotemax, it suggests that Restasis or Xiidra or one of those medications may help. So we wanted to do a Lotemax trial, and we told the patient, since she wants to continue wearing contact lenses, that we would try to fit her in Sclerals at the next visit, or in the near future, after we could maybe get some of the symptoms under control. The patient came back in 2 weeks, and she noted that the Lotemax didn't help. That's not uncommon, and actually something only like 10 or 12% of patients do respond well to Lotemax and Xiidra and those sort of things. So what we ended up doing is just going right to the scleral lenses. That is an approved advanced dry eye treatment. We went with a MSD, which is from Blanchard, which I think is also now owned by CooperVision, but it's a pretty commonly used scleral lens in the United States. We went to the fitting guide and we picked out sagittal height of the contact lens based upon the patient's case. For the right eye, we started with a 4.4 sag. In the left eye, we started with a 4.6. We put it on the patient's eye. Then we noted that the lens itself had no power. We did an overrefraction after we let it settle for about a half an hour, which is pretty standard for scleral lenses. And then we did our overrefraction, and we found that she had about 3 diopters residual refractive error in the right eye and about 475 in the left. We evaluated the fit, and we noticed that there was some slight conjunctival blanching, meaning that the lens is too tight or too steep in the periphery. But it was a trial lens, and I didn't really want to mess with the periphery too much because it wasn't that bad at that time. We also noted the central clearance was around 350 and 400. So we look at how far away the center part of the contact lens is away from the cornea. And this is a little steep, 350 and 400. The ideal these days is around 250, but I think it's good enough for a trial lens. So what we did is we ordered a lens. This is the lens we ordered. We kept the same sag, same periphery, the standard periphery, and ordered it, had the patient come in to try it on. We put it on. She could see 20/20 in the right eye and 20/30 in the left. Not ideal for the left, and that's probably because she had some over-refraction left. So she had almost no over-refraction in the right eye. The central corneal clearance was good. The left eye had about 1.25 diopters worth of over-refraction, so we had to correct for that. And we also noted in the periphery when we evaluated at this time that there was much more conjunctival blanching, meaning that the blood vessels were getting squished because the periphery was too tight. So we wanted to, at this point, to flatten the lens. So we did not send this lens home with the patient because we didn't think it was safe. So what we did is we called the lab and told them what was going on, and they helped make adjustments because there was a few things going on. The edges were changed, there was over-refraction, and that could change the base curve and all that stuff. So I just called the lab, and they helped us create this lens, which we had them send to the office. And actually, we just let the patient pick them up in office because at that point I felt like it was good enough for the person to try, and it would just be, one visit that they didn't have to come in for a full exam. So that patient came in and was wearing the lenses, had been wearing the lenses for say 7-8 hours, no comfort issues. The fit looked good. There was really no over-refraction. The patient was seen 20/25 and 20/20, but really 20/20 overall, and was pretty happy. There was no over-refraction. The central corneal clearance was good, and the edge was good with that one flat. So overall, the patient was happy. We ended up finalizing that set of contact lenses. Scleral lenses really have a resurgence in the last 10 plus years. There's better materials, better designs, lots of companies making them. And because of that, it's actually becoming a standard of care for advanced dry eye patients or patients with contact lens discomfort. And I actually recently had the opportunity to help with the CLEAR report, which is through the British Contact Lens Association. CLEAR is the contact lens evidence-based academic report, and I was on the medical use for contact lens section, and I actually wrote the section on scleral lenses. And we found overall that scleral lenses are very well proven for treating patients who have contact lens discomfort and advanced dry eye. People who have viral eye disease that cause scarring, like all different kinds of reasons for this bad dry eye can be treated with scleral lenses. So a couple take-home points. One, just ensure that you're monitoring your patients closely. If they have some symptoms, try to treat it early because you want to prevent contact lens dropout. And you want to be monitoring these patients throughout their contact lens life. So you want to monitor them closely after their first time wearing contact lenses. You want to be checking in with your established wearers pretty regularly. And then you for sure want to check up on them, see how they're doing with presbyopia, because the visual, issues that come with presbyopia frequently make patients drop out of contact lenses. So monitor them closely, and really overall is if they have motivation to wear contact lenses, they're probably going to be able to be successful if you just give them different options. It may have to be a more complex option, but I think that they can make it. So with that, I think I'm about on time. I'll take questions, and I appreciate all your attention.
All right. So thank you, Dr. Paka, so much for that I think the case which you talked about, all 4 different cases, and I think I understand that you can have a variety of contact lens wearers in your practice, and probably most of them might be suffering, and you should know how to deal with them individually, right? So it's not only with a particular type of lens that you will have dry eyes or symptoms, discomfort as their problem, but variety of range of lenses, people might have those problems.
Exactly. Roughly 80% of contact lens wearers have some symptoms. We just want to make sure that it's not all the time and not too bothersome. So no matter what kind of contact lens it is, you want to be checking in, asking those questions I mentioned. And if they're having issues, you try to want to cut it off quickly as you can.
That's right. Just before we go to the question, just one which I would like to just, ask you straight away is, you did mention about using questionnaires in your contact lens practice to make sure, or to, check the symptoms of the patient. So any favorite questionnaire, because we do know there are many out there. Any favorite questionnaire you think is more evidence-based? All are evidence-based, to be really honest, but any of your personal favorite questionnaire which helps you a lot?
I think my 2 favorites are, one, the Contact Lens Dry Eye Questionnaire 8, which I mentioned several times. It's easily downloadable. It was created by Robin Chalmers and several people. I did a Roche analysis study on it, finding that it was very repeatable and the psychometrics are good. So I like that one. Also, I've been commonly using the Speed Questionnaire. It was made by Don Korb in the mid-2000s, and I like it because it's simple. It asks the dry eye specific questions, and it's pretty predictive of dry eyes. So I stick to those, but there's many surveys you can pick from. So if those don't meet your practice's specific needs, you could do the OSDI or a whole host of other ones out there.
Okay. And just taking a couple of questions here. This is about the prescribing of artificial tears. There are a lot of them in the market. Do you have any specific way on choosing which one would suit that patient? Is there anything you look for specifically before prescribing that particular patient?
There's a couple of factors. So one is, you have a person who needs to use artificial tears many times a day, so more than 4 times per day, I would recommend trying to find one that's not preserved. So preservative-free would be best for that one. The other thing is, there's now drops that have lipids in it. So there's the Sustain Complete I mentioned. I didn't go into the details of it, but it has a lipid component, so it's indicated for evaporative dry, and there's also a lubricant in it that's indicated for aqueous deficient dry eye. So it's kind of a 2-in-1, but that's kind of my personal preference. The meta-analysis I pointed out suggests that there's really no difference between the drops on the market. So if you have Sustain Complete, which might be $20 a bottle in the United States, and there's another one out there that's much cheaper for your patients, say maybe they can't afford the $20 bottle one, I think maybe the cheaper one is okay as well. It's just getting them to do it regularly. If they need it 4 times per day, try to get them to take it 4 times per day. That's the compliance thing is a big issue.
Yeah, that's right. Okay, so it's a multifactorial thing. We need to look at what the patient actually is deprived of, and probably choose it from there forward from there.
Yeah, if they have evaporative dry eye, which is about 80% of dry eye patients, then maybe you want to find the lipid one.
That's right.
But there's different ways you can tailor it, but I try to keep it simple.
That's right. Okay. And most important is you need to get them to use it as per the recommendation. That's the challenge.
Yeah.
Yeah. So suddenly they feel good, they are fine, then they probably stop using it, and then they come back to you with the same complaints, and then they think that it's a kind of a management which was there for it's like antibiotic. Use 5 days and then you are done for the rest of the month. But it's not like that. It's a continuous thing, and they need to understand that.
That is a very common patient issue. They just stop taking the drops and they're like, oh, why'd I get worse? Because you stopped taking the drops.
That's right. Yeah. So again, patients education, and again, I would emphasize that we play a very important role as optometrists in terms of patients education as well. Right.
Yeah.
Okay. So the next question is related to the ointment perspective. So in probably dry eye patient, ointment is discomforting and patient discontinue to use it. So would you recommend to put them on a teardrop while applying the gel? So it's kind of a question where would you shift them to the teardrops if they're already using gel, or if I may put it or rephrase it, do you recommend patients to use ointments if they need so with the lenses on or something like that? If you would,
if I prescribe an ointment to a patient, it's generally before bed. So a lot of people don't fully close their eyes, and the ointment is very handy for those patients, or if they're in a room with a fan when they're sleeping, that can help. If a patient needs to use an ointment during the day, I think that they need some other treatment like Sclerals or a medication, something stronger, because the ointment is kind of disorienting to vision. They may not be able to, function fully, and there's a goopiness that's on their eye, and they probably don't want that, walking around in public, right? So I might go more with your emulsion, kind of basic artificial tears, or if that's not enough, then I might ramp up the treatment level to Xiidra, a dry eye specific medication with the artificial tears or scleral lenses or amniotic membrane, which I guess is for really bad patients. But you kind of work your way up, and once tears fail, you do the next one.
that's right. Okay. And this is again kind of a side diversion from the current talk we had, but it might be related somewhere. So that's why I took that question. Why do you think that diabetic patients are not good candidates for contact lenses? First is, do you think that they are not good candidates? That's the add-on. And if you think they are not, why? If you would like to highlight something here.
I think it's totally okay for a diabetic to wear contact lenses these days. We now have materials that are very breathable. So 40 years ago, when you had, just hard PMMA contact lenses that didn't breathe, then maybe you don't want to induce hypoxic stress in a diabetic that would maybe further exacerbate their disease. But modern contact lenses, very, very breathable, and I think totally safe for your diabetic patients.
That's right. So there is no rule or saying that diabetics cannot wear contact lenses. I think probably you just need to evaluate that tear status or tear function well, which we always do. I mean, it's not related to only diabetic patient, but we always evaluate the tear function of our patients, whether it is a diabetic patient or not. And that would help. As you said, recent materials, advancement in the materials are so good that it would probably be not much of a problem. And coming back to your own point again, which you mentioned, I guess in case one, that regular follow-ups. So probably they might need a regular follow-up to make sure that the ocular health is maintained, right?
Yes. Yeah.
Okay.
I guess just thinking about demographics and diabetes, my really bad diabetic patients tend to be 60 years or older, and they're not usually wearing contact lenses anyway, but there are young diabetics too. So I guess you got to look at it a little bit on a patient-to-patient basis. But probably safe.
That's right. Yeah, yeah. And one more question here, again, side a bit of this thing, I think related to your case 4, probably on the scleral lens. Do you have any experience on patients who have undergone cataract with IOL and have dry eyes complaints because of that surgery, and any experience on fitting those kinds of patients with scleral lenses?
Yes, so it's very common to have dry eye after cataract surgery. It frequently gets better with time. And the likely reason you're having some symptoms is because the corneal nerves were cut. So you're altering the ocular surface along with the surgery. So a lot of people get better, but if they don't, say they have persistent dry eye, then I might go with a scleral lens. And it could be a very good option for that patient. It's good ocular protection there. And the one thing that you got to watch out for, though, is if they have really bad nerve damage, they may have something called neuropathic pain. And if they have neuropathic pain, the scleral lens itself may not fix the disease. It may not fix the discomfort. So if you are worried about that, you can put a drop of piperacane or a numbing drop on the eye, and if it gets better, that suggests that the stimulation is coming from external environment and the scleral lenses should work. But if the drop doesn't help, then they may need to be referred to a neurologist who could help with pain medications. So that's a complex answer, but
yeah. So you need to look
it should
at
work.
all aspects.
Yeah, it should work with most patients.
That's right. Yeah. And I think you did mention again that scleral lenses in your very last 2 slides, that scleral lenses have become more famous on management of discomfort, and they are not on, they are also termed as therapeutic lenses for dry eye management and kind of that. So if your patients have that discomfort and dryness symptoms, I think scleral lenses work wonders for them, as you said.
It can be life-changing.
Life-changing.
Yeah.
All right. One last question. This is a kind of a case. A 24-year-old patient wants to wear contact lenses only on the weekends for his sport activities and mountaineering. So any suggestions on what would be the choice of contact lenses? He has a minimum kind of astigmatism. Vision is 20/20 or 6/6. But this is the kind of details we have from the patient demographics. Would you have any suggestions of contact lenses for him?
Well, as a category, I think daily disposable contact lenses would be perfect because they're only wearing them, it sounds like 2-3 days a week for sports, exercise, that sort of thing. It's actually cheaper for them to buy daily disposable usually if they're wearing them that infrequently compared to your 2-week or 1-month lenses. So it's cheaper for the patient. It's probably healthier for your patient because they're not having them sit around in a case for a week while they, do their other stuff, come back to the weekend for their activity. And, there's the daily disposal have less time, to have bad things like bacteria build up. A specific contact lens, I don't have a specific preference. You could do Clarity, Dailies, Total One, like I mentioned in this talk, AccuView Oasis one day. There's lots of them out there. I don't fully know what's available in India, but really any good daily disposable will be perfect for that person.
That's right. So I mean the take message here, I would say, is the patient only wears occasionally, so a daily disposable would work well. And the kind of activities what the patient wants to do is spotting and mountaineering. So again, daily disposable in terms of hygiene, as you mentioned as well. So it will be much more beneficial for him not to get him drop out very soon, and keeping him into contact lens practice and let him enjoy his vision for that 2 days what he wants to.
Exactly.
Yeah. So I think we have taken most of the questions which were on the chat. Thank you so much, Dr. Paka, for doing this and taking us through the case journey. Again, the case was, as you mentioned, it's kind of a progressive case. We started from the basic ones and then progressed to a specialty scleral lens. And thank you so much for doing that for us.
Happy to. Thanks for having me. This was wonderful.
And we do have sessions planned next weekend. Until then, stay safe, take care, and I will see you all again next weekend. Take care and bye-bye. Thank you, Dr. Prakash, so much.
Thank
Bye-bye.
you.
Yeah, have
Bye.
a good evening. Yeah.
You too.